Before we go any further, I need you to pause. Because what I'm about to tell you may completely change how you look at your cholesterol report. Right now, millions of adults over 60 are terrified of the wrong number. They're cutting foods that may actually protect them. They're taking medications they may not need. They're losing sleep over LDL. While a far more dangerous number sits quietly on the same lab report, ignored. And as someone who has spent decades studying vascular disease and stroke prevention, I can tell you this with complete clarity. The cholesterol number most doctors obsess over is not the strongest predictor of stroke in seniors. And that misunderstanding is costing people their independence. I'm Dr. Christina Serrati. Over the years, I've worked with patients who believed they were safe because their LDL was under control, only to suffer devastating strokes months later. I've also seen patients with high LDL who remained stable and cognitively sharp into their 80s. So what makes the difference? Let me tell you about two women I evaluated last year. Both were 74. Both had routine cholesterol panels. The first woman had an LDL of 168, which alarmed her primary doctor. She was immediately placed on a high-dose statin. She was warned. She was scared. She thought a stroke was imminent. The second woman had an LDL of 112. Her doctor reassured her. "Everything looks fine," he said. "No changes needed." Within a year, the second woman experienced a major ischemic stroke. The first woman did not. Why? It wasn't LDL, it was her HDL and triglycerides. The first woman had strong protective HDL levels and low triglycerides. The second had severely low HDL and triglycerides over 280, but no one focused on them. And here's the truth most people aren't told. In adults over 70, LDL becomes a surprisingly weak predictor of stroke risk, but low HDL, high triglycerides, those are powerful warning signs. And there's one ratio, almost never discussed, that predicts stroke risk better than LDL alone. At the end of this series, I'm going to show you how to calculate it yourself in under 10 seconds. But first, you need to understand why the old cholesterol model doesn't fully apply to aging arteries. Because if you're over 60, your vascular biology is not the same as a 45-year-old's, and that changes everything. Now let's talk about something that may surprise you. For decades, we were taught a simple rule: LDL is bad, HDL is good, lower LDL at all costs. That model works reasonably well in middle-aged adults. But after age 70, the picture changes. As we age, our arteries don't behave the same way they did at 40 or 50. Plaques that formed earlier in life often stabilize. The body adapts. Inflammation patterns shift. Immune function changes. Hormone levels change. Even how cholesterol is used by the brain changes. And here's the critical part. Several large long-term studies in adults over 70 have shown that LDL alone is not a strong predictor of stroke in this age group. In fact, in some elderly populations, extremely low LDL has been associated with higher overall mortality. Why? Because cholesterol is not poison. Your body uses it for cell membrane integrity, hormone production, vitamin D synthesis, brain function, immune system support. Your brain alone contains nearly 25% of your body's cholesterol. So aggressively driving LDL extremely low in older adults doesn't automatically equal better outcomes, especially if we ignore the other lipid markers that drive inflammation and clot formation. And here's where most conversations go wrong. LDL is a measurement of cholesterol carried inside particles. But it does not tell us how many particles you have, whether they are large and buoyant or small and dense. Small, dense LDL particles are more likely to penetrate artery walls and trigger plaque formation. And what increases those dangerous small, dense particles? High triglycerides. And what usually accompanies high triglycerides? Low HDL. This is where the real metabolic story begins. When HDL is low and triglycerides are high, it often signals insulin resistance, even if you've never been diagnosed with diabetes. And insulin resistance creates chronic inflammation, endothelial damage, increased clotting tendency, thickened blood viscosity. Those are stroke accelerators. So instead of asking only, what is my LDL? A far more important question after 60 is, what is my HDL doing? And are my triglycerides under control? Because HDL isn't just a cholesterol transporter, it has anti-inflammatory properties. It helps repair artery linings. It reduces oxidative damage. It even influences clot stability. Low HDL removes that protective shield. And when that shield is gone, plaque becomes unstable. An unstable plaque is what breaks loose and blocks brain arteries. That's how ischemic strokes happen. In the next section, I'm going to show you the two numbers that together predict stroke risk far better than LDL alone, and the simple calculation almost no one is taught to use. Once you see it, you'll never look at your lab report the same way again. Now we're getting to the part most people have never been told. If you're over 60 and you want to understand your real stroke risk, there are two numbers on your lipid panel you must look at immediately: your HDL, your triglycerides. Let's start with HDL. For women, HDL should ideally be above 50. For men, above 40, though I personally prefer to see it above 55 in both. Why? Because HDL is not just good cholesterol, it's protective cholesterol. HDL helps remove excess cholesterol from artery walls, reduce inflammation inside blood vessels, prevent LDL oxidation, which makes it dangerous, improve endothelial function, reduce abnormal clot formation. When HDL drops too low, those protections weaken, and stroke risk rises significantly. In seniors, HDL below 40 to 45 is a serious red flag. Now let's talk about triglycerides. Triglycerides are fats that circulate in your blood, largely influenced by sugar intake, refined carbohydrates, alcohol, and insulin resistance. Optimal triglycerides should be under 100, above 150. Concerning, above 200. High risk, above 300. Severe metabolic dysfunction. When triglycerides rise, several dangerous things happen. LDL particles become smaller and denser. Blood becomes more prone to clotting. Inflammation increases. Worsens. This combination creates unstable plaque, the kind that ruptures and blocks brain arteries. But here's where it becomes powerful. When HDL is low and triglycerides are high together, stroke risk multiplies. And this leads to the calculation I teach every patient. Triglycerides divided by HDL. It's simple. Let me show you. If your triglycerides are 200 and your HDL is 40,200 divided by 40 equals 5, that ratio is high risk. Here's how I interpret it. Under 2 gives excellent metabolic health, 2 to 3 gives acceptable, 3 to 4 gives moderate risk, above 4 gives high stroke risk, above 6 gives severe risk pattern. This ratio reflects insulin sensitivity, inflammation, and vascular stress all in one number. And yet almost no one talks about it. Most patients are told only, your LDL looks fine. Meanwhile, their ratio may be 6 or 7, silently signaling danger. This ratio predicts metabolic dysfunction better than LDL alone. And metabolic dysfunction is one of the strongest drivers of ischemic stroke in aging adults. Now in the next section, I'm going to explain something even more important: why many cholesterol medications don't fix this pattern and what actually does. Because lowering LDL does not automatically correct a dangerous triglyceride to HDL ratio. And that distinction matters more than you think. Now let's talk about something that makes many of my patients uncomfortable at first. Because it challenges what they've been told for years. If your main issue is low HDL and high triglycerides, a statin may not be fixing the real problem. Statins are excellent at lowering LDL. They can reduce LDL by 30 to 50%, sometimes more. But here's what they typically do to the numbers that matter most for stroke risk in seniors. HDL. Mild increase, maybe 5 to 10%. Triglycerides. Small reduction, often 10 to 20%, that's modest. So if your triglycerides are 260 and your HDL is 35, bringing LDL from 140 down to 80 doesn't dramatically change your metabolic risk pattern. The dangerous ratio may still be there. And here's the key. High triglycerides and low HDL are often driven by insulin resistance. Statins do not fix insulin resistance. In fact, in some individuals, high-dose statins can slightly worsen blood sugar control. That's not fear-mongering. It's physiology. If the root driver is metabolic dysfunction, meaning your body isn't processing sugar efficiently, then the strategy must address that metabolic pattern. That means reducing refined carbohydrates, improving muscle mass, increasing insulin sensitivity, lowering inflammation. There are medications that specifically target triglycerides, such as fibrates and prescription strength omega-3 formulations. These can reduce triglycerides more substantially. But even more powerful than medication, lifestyle interventions that directly raise HDL and lower triglycerides. And I'm not talking about casual walking once a week. I'm talking about targeted, consistent changes that shift your metabolic biology. Because here's the reality. You cannot out-medicate a high-sugar, sedentary lifestyle. And I say that gently, not judgmentally. I've seen patients reduce triglycerides by 80 to 100 points in 3 months simply by eliminating sugar, removing white flour, reducing alcohol, increasing resistance training, losing abdominal fat, and when triglycerides fall, HDL often rises. When HDL rises, arterial inflammation drops. When inflammation drops, plaque stabilizes. And stable plaque does not rupture and cause stroke. Now in the next section, I'm going to walk you step by step through the specific lifestyle actions that produce the biggest improvements in HDL and triglycerides. These are not vague suggestions. They are precise levers that move your numbers. And when you understand them, you'll see just how much control you actually have. Now we move from theory to action. If your HDL is low, if your triglycerides are elevated, if your ratio is above 4, these are the interventions that create measurable change. Not gimmicks, not trends, physiological levers. Let's go step by step. 1. Remove sugar and refined carbohydrates completely. This is the fastest way to lower triglycerides. When you consume sugar or white flour, your liver converts excess glucose into triglycerides. That's biochemistry, not opinion. Eliminate sugary drinks, desserts, white bread, pasta, white rice, pastries. Many patients see triglycerides drop 50 to 100 points within 6 to 8 weeks. That alone can cut your ratio dramatically. 2. Increase protein and non-starchy vegetables, replacing refined carbs with eggs, fish, chicken, Greek yogurt, leafy greens, cruciferous vegetables. Improves insulin sensitivity and reduces inflammatory signaling. 3. Prioritize resistance training. This is critical, especially after 60. Muscle is a metabolic organ. The more lean muscle you maintain, the better your body processes glucose and triglycerides. You don't need bodybuilding. You need 2 to 3 resistance sessions per week, light or resistance bands, progressive strength work. Improved muscle mass directly improves triglycerides and HDL. 4. Add moderate to vigorous cardio. Brisk walking is good. But to raise HDL significantly, intensity matters. Activities like fast uphill walking, cycling, swimming, interval training done consistently can raise DL by 5 to 15 points over time. 5. Reduce alcohol. Even moderate alcohol intake can elevate triglycerides. If your triglycerides are above 150, consider eliminating alcohol entirely for 8 to 12 weeks and retest. Many patients are shocked at the improvement. 6. Increase omega-3 intake. Fatty fish 2 to 3 times per week. Or high-quality omega-3 supplementation, EPHA, under medical guidance. Omega-3 South help lower triglycerides and reduce vascular inflammation. 7. Lose abdominal fat. Visceral fat drives insulin resistance. Even 5 to 10 pounds of weight loss can significantly improve HDL and triglycerides. You do not need to be thin. You need to reduce central inflammation. 8. Stop smoking. Smoking lowers HDL and damages arterial lining directly. Quitting improves HDL within months. If you implement these consistently for 3 to 6 months, most people see HDL rise 10 to 20 points, triglycerides fall 50 to 100 points. Ratio normalized dramatically. That is not theoretical. I see it every year in clinical practice. Now in the next and final section, I'm going to tie everything together, including one overlooked genetic marker that changes your risk profile completely. And I'll give you a simple checklist you can use today when you review your lab results. Before we finish, there's one more piece most people never hear about. And if you have a family history of stroke or early heart disease, this matters even more. It's called lipoprotein A. often written as LPA. This is not part of a standard cholesterol panel. You have to specifically request it. LPA is a genetically determined LDL-like particle that is more inflammatory and more prone to clot formation. If it's elevated, typically above 50 mg DL, stroke risk increases significantly. And here's the key. Lifestyle changes don't lower LPA very much. Statins don't meaningfully reduce it. It's inherited. So why test it? Because if your LPA is elevated, you cannot afford to ignore any other risk factor. Your HDL must be strong. Your triglycerides must be controlled. Your blood pressure must be optimal. Your blood sugar must be stable. Knowing this number changes how aggressively we manage everything else. Now let me give you your practical stroke prevention checklist. Pull out your last lipid panel. Look at these 4 things. HDL women. Aim above 50, ideally 55 to 65. Men. Aim above 45 to 50 triglycerides optimal, under 100. Concerning. Above 150 high risk. Above 200 triglyceride to HDL ratio. Under 2 gives excellent, 2 to 3 gives acceptable, 3-4. Gives elevated, above 4 gives high risk, above 6 gives severe metabolic dysfunction, LPA. If tested. Under 30 gives ideal, 30 to 50 gives watch closely, above 50 gives elevated genetic risk. Now here's the part that requires nuance. LDL is not irrelevant. But in seniors, LDL without context can be misleading. If your LDL is 150 but your HDL is 65 and triglycerides are 90, your metabolic risk profile may be stable. If your LDL is 105 but your HDL is 35 and triglycerides are 240, your risk may be much higher. It's the pattern that matters. Stroke is rarely caused by one isolated number. It's caused by inflammation, plaque instability, clot tendency, and metabolic dysfunction over time. And the triglyceride to HDL ratio captures that pattern more clearly than LDL alone. So here's what I want you to do today. Review your numbers. Calculate your ratio. Identify which lever you need to pull. Then commit to 3 to 6 months of focused correction. Because preventing stroke isn't about fear, it's about clarity. When you understand the right numbers, you stop chasing noise and start correcting risk, and that shift alone can change your future. I'm Dr. Christina Serrati, and your brain deserves better than outdated cholesterol myths.